topic. I will be talking on the supportive care of a ventilated child. The term supportive care by itself is a very broad term which can include a lot of things, right from the basics like monitoring a child on ventilator, general care which is often neglected as nursing care, sedation, analgesia, nutrition and fluids, followed by infection control measures, and the end point is extubation. So the general course of ventilation in a pediatric ICU starts with intubation, the initial period of ventilation where the ventilator supports are quite high depending on the pathology for which the child is being ventilated. Then starts the phase of weaning or recovery, during which apparently the child is getting better or the pathology is getting better, followed by extubation, and 24 hours post extubation where the risk of extubation failure is high. This is how the majority of ventilation course runs in the PICU. So how do we monitor a ventilated child? These are basic things which we do day in and day out at the bedside of any sick child, which includes clinical monitoring, making use of multipara monitors, then use of ventilator parameters per se, some ancillary data from radiology, capnography and blood gases can be useful. The aim of monitoring is to pick up any problems early and troubleshoot it. Clinical monitoring, again basics, vital parameters like heart rate, saturations and blood pressures, chest expansion, air entry with respect to a ventilated child. The work of breathing and the patient comfort on the ventilator is also important and to be monitored by the clinician at the bedside. Next important thing is the tube tip level, which has to be monitored by the clinician and the nurses as well. When dealing with the ventilated or a critically ill child, it is useful to have a checklist. The commonly employed checklist of fast hugs bed, feeding, analgesia, sedation, thrombo prophylaxis, head end of bed elevation, ulcer prophylaxis, glucose control, spontaneous breathing trial, bowel care, catheter removal and de-escalation of antibiotics. This is a list which is borrowed from adult ICUs and has been put to use in pediatric ICUs. In addition to this, ventilator specific charts are available and are made to be filled up by the clinician or the nurses at the bedside to monitor hourly changes. These are the basics which can be done without use of any advanced equipment. Next come the blood gases. With respect to a ventilated child, blood gases are significant to understand whether the child is improving or not. Arterial gases, yes, if the child is being ventilated for a pulmonary pathology. Venous gases for a non-pulmonary pathology should be sufficient. End-tidal CO2, the use of it has significantly reduced the number of blood samples or invasive blood sampling for arterial blood gases. There is no role for routine blood electrolytes or any organ function monitoring. It has to be individualized based on the disease process. A few words about capnography. It is the estimation of CO2 in the expired air. It serves as a surrogate to assess the adequacy of ventilation. It is an indirect marker of the arterial CO2. The arterial CO2 is usually 4 to 5 above the ET CO2. In case of an increase in dead space, then the gradient increases and this makes us suspicious of any pulmonary worsening. In the PICU per se, the uses of capnography starts from the confirmation of endotracheal tube placement to identify the nature of airway obstruction in some cases like bronchospasm, to serve as an indicator of return of spontaneous circulation during CPR, and it can be combined with pulse oximetry to reduce the need for blood gases. Radiological monitoring, a baseline chest X-ray is essential after intubation to confirm the tube position. The usual position recommended is between T1 and T2 level, that is a midway between thoracic inlet and the carina. Point to note is in smaller babies, the head position can significantly affect the tip of the ET tube position, and that has to be kept in mind. Routine repeat X-rays like daily or twice every 48 hours are not needed and has to be done only when you suspect something specific. Point of care ultrasound is coming up in a big way now, and it can detect most of the pulmonary pathologies. Lung ultrasound has been used for effusions, collapse, air leaks, and in some cases also to confirm the position of the endotracheal tube. What do we monitor on the ventilator per se? The things we encounter on the bedside, ventilator alarms, provided you set it properly at the initiation of ventilation, they are going to be useful in troubleshooting. The blind mnemonic to follow is recommended by PALS is DOPE in case of any acute deterioration, suspect displacement, obstruction, pneumothorax and equipment failure. The pathology could be patient related to the endotracheal tube or to the ventilator or the circuit. I'll just give an overview of troubleshooting. Troubleshooting is an exhaustive topic per se, so I will not be going into the details. High pressure alarms commonly encountered at the bedside. High peak inspiratory pressure can be triggered by a simple cough or a simple patient who has not been adequately sedated. When there is a high peak inspiratory pressure, once you have ruled out the other causes, then check the plateau pressure. For this, the child needs to be sedated and paralyzed. If it is a normal plateau pressure, then the pathology is somewhere in the airway. That is in a simple way to remember. If there is a high plateau pressure, suspect that your lung is worsening. There is something causing the decrease in the lung compliance. Other things which are commonly missed, the endotracheal tube impinging on the carina or gastric over distension can also trigger high pressure alarms, and these have to be kept in mind while troubleshooting. Low tidal volume alarms, this can be in two scenarios. When you have already set the tidal volume and the patient is not generating it adequately, check if the pressures are inappropriately high, then go back to the previous algorithm. If the pressures are normal or low, then check if there is a leak in the circuit or around the ET tube. In a pressure control mode, in other words, you have set the pressure but still you are not able to generate adequate tidal volumes. The first thing, the common thing to remember is the child breathing against the ventilator or are there any spontaneous breaths? Then identify the cause of ventilator asynchrony and correct it. If it is an already paralyzed or a sedated child with no spontaneous breaths, then think of other pulmonary pathology starting from the airway pathology or a parenchymal pathology. This is just an overview of troubleshooting. The list is quite long. If there is a sick patient or a deteriorating patient, there are multiple alarms triggered at the same time. So I'm not going into the details of that. Similar thing about ventilator graphics, they are a topic of discussion per se. All modern ventilators are microprocessor based, so they can give you breath to breath information regarding the flow, the pressure, the volume, which is charted against time. The scalars and loops, now it is becoming part of basic ventilation training. They can give you multiple informations and can aid in troubleshooting also. So care of tubes, these are all basic nursing care which we do day in and day out, and I'll be adding a bit of evidence to each of it. Endotracheal tube taping, there are multiple ways by which we do it. The one shown in the image is a Melbourne strap, which is commonly followed in pediatric ICUs. I have seen anesthetists doing it in a slightly different way. The security of the ET tube has to be assessed every hour and has to be charted, and tapes have to be replaced as and when required. If and the medical staff on the floor have to be aware at what position the ET tube is fixed. It is measured from the central incisor or the alveolar ridge. Cuffed or uncuffed ET tube, the current AHA recommendation says use a cuffed tube whenever possible. The incidence of adverse effects between cuffed and uncuffed tubes are similar. The risk of subglottic stenosis or stridor, etc. are found to be similar. There are no trials to say which is superior, but still the recommendation is to use a cuffed tube wherever possible. The risk of reintubations in case of leaks or difficult ventilations can be avoided. If a cuffed tube is being used, monitor pressures. The ideal pressure to target is 20 to 25 millimeters of mercury. It has to be checked every 6 to 8 hourly at the bedside. Suctioning, again a common bedside nursing procedure to maximize the amount of secretions while minimizing interruptions and interruption in ventilation, thereby minimizing adverse effects. It does improve gas exchange, oxygenation if done properly. A suction catheter routine size is twice the ETT size, which is a rough number to remember. Use of blunt tip catheters, silicone catheters if the child is on long-term ventilation, though they are expensive, they can reduce the risk of infections. The pressure, the wall pressure to be set is different from adults. It is less. It is about 80 to 100 or even lesser if it is a smaller child or a bleeding child. The depth of suctioning has to be only up to the length of the endotracheal tube. Deep suctioning, unless you are targeting to obtain a bronchoalveolar lavage, is not to be done routinely because there is a risk of mucosal injury. Saline instillation, again not routinely recommended. The risk of contamination is there. So only if there are thick secretions, use saline instillation or hypertonic saline nebulizations. Inline catheters in children who are extremely PEEP dependent or pressure dependent, they do not tolerate even slight disconnections. In that case, inline suction catheters can be used. Chest physiotherapy or other adjuncts like bronchoscopy, etc. can be used as and when required. Humidification is an essential part of smooth ventilation. It preserves ciliary function and prevents thickening of secretion. The temperature range recommended is 33 plus or minus 2. There are modern humidifiers, heated humidifiers available. The one shown below is a newer one which has a graphic display and can be used for invasive and non-invasive ventilation or for HFNC. The heated wire circuits, the condensates accumulating in the circuit is less, so the risk of transferring it to the patient and thereby causing infection is much lesser. They are very commonly used in the pediatric ICUs nowadays. The cheaper alternative is a HME or the heated moisture exchanger, which is used for short term or transport. They are associated with risks in that they are heavy, they are bulky. In a small child, they can add to a significant amount of dead space and air trapping, etc. If you are using them, make sure they are changed every 24 to 48 hours or as and when they are soiled. General care, often relegated as nursing care by the physicians, is very important in improving the quality of outcome. Oral and eye care, the recommendation is to do thrice daily oral hygiene or cleaning with 2% oral chlorhexidine or brushing. Frequent suctioning will prevent microaspirations, has proven to show reduction in the incidence of ventilator-associated pneumonia. Eye care, the absent blinking and in a dry environment and air-conditioned environment, they develop exposure keratitis very quickly. Use of artificial tears every hourly or 2 hourly with lubricating eye ointments, followed by taping. Simple eye taping can also be useful. Skin care, skin breakdown does not only occur in long-term patients, it can occur on day one in a sick child who is fluid overloaded or who is on multiple supports. Daily bathing with 4% chlorhexidine solution is the recommendation. There are multiple gradings or charts available to assess skin integrity, which the nursing staff can be educated and daily markings can be done. Regular skin and tissue assessment, skin care with moisturizers, zinc oxide creams in the diaper area. The most important one, repositioning the child every 2 hourly if there are no contraindications. A sedated paralyzed child can be at risk of multiple skin breakdowns. Older child, DVT prophylaxis or pneumatic compression pumps can also be considered. The other component of ventilation which is often forgotten, which is sedation and analgesia. Sedation, the goal is to minimize anxiety, pain and discomfort. There are a lot of recent trials coming up with respect to post-traumatic stress or post-ICU delirium in pediatrics because of underuse of sedation or awake ventilations, which can be quite traumatic, especially in older children. Wide variation in sedation practices. Some units do not use infusion, some units just use boluses, so there is no still uniform protocol. Depth of sedation, if you over sedate them, they can be ventilated for a long time, can have other adverse effects of ventilation. Under sedation is obviously associated with catheter displacements or tube displacements, etc. There are scales available for sedation in the ventilated child, the state behavioral scale, comfort scale. These are all been validated in the PICU by extensive studies. Daily sedation interruption, like you give a holiday of sedation for 3 to 4 hours every day on a ventilated child, is still part of a unit practice in many big units, but there is no definitive evidence to support the same. Common drugs, the common practice is to start with an infusion of an opioid and a combination with the benzodiazepine, depending upon the hemodynamics and the general condition, and titrate up or down as per the child's tolerance level. Point to remember is prolonged usage, both opioids and benzodiazepines can cause tachyphylaxis, can cause withdrawal symptoms, so that has to be kept in mind, and alternative agents have to be switched over once we have reached day 5, day 6, etc. Dexmedetomidine is a newer drug which is coming up in a big way, which is part of regular sedation protocols in many of the pediatric intensive care units. It is a mild sedative anxiolytic. It helps us reducing overexposure to opioids or benzodiazepines, and peri-extubation, the child can be extubated while on dexmedetomidine, but it does not cause respiratory suppression. Enteral adjuncts like triclofos or clonidine, or even making simple measures like making the caregiver sit at the bedside, reducing bright lights, reducing loud sounds can improve your sedation scores. Analgesia becomes important in a post-traumatic child or in a post-operative child where there is moderate to severe pain, especially in the ICU when the child is ventilated. In such cases, opioids become the first-line analgesics. They are extremely helpful because they provide analgesia and sedation as a single agent. For short-term use, they are wonderful drugs, but prolonged usage, they come with their own side effects. Non-opioids like paracetamol, NSAIDs can be used as adjuncts, but they may not work alone. Clonidine, dexmedetomidine, though they are not analgesics per se, they are commonly used as part of a multi-drug protocol. Neuromuscular blockade, the use of neuromuscular blockade has come down significantly in the pediatric ICU units. They are used as short-term measures Common drugs like vecuronium, atracurium, rocuronium, succinyl-choline. The indications as part of rapid sequence intubation to prevent ventilator asynchrony. The solution is not just to paralyze the child, but to identify why the patient is asynchronous. It can be used to reduce barotrauma or ventilator-induced lung injury, especially children on very high pressures, to keep ICP spikes low in a traumatic brain injury child. They also come with their own side effects when used for prolonged time, like myopathy or polyneuropathy, and they may require prolonged rehabilitation. Nutrition is often forgotten when initiating ventilation because there are a lot of critical care things happening around a ventilated child, and nutrition always takes a back seat. Point to remember is nutrition plays an important role in a significant role in the intact outcome of children who are ventilated. Ventilated children generally have very less calorie requirements because they are sedated, they are paralyzed, the insensible losses are all eliminated. How do you assess an accurate energy requirement for a child? You need indirect calorimetry, which unfortunately is not available in every unit. There are formulae available which give us a rough estimate of the calorie requirement for that individual child. Weight-based calorie requirements can be used as a rough marker. Proteins, we start with 1 to 1.5 grams per kg per day and go up to 4 grams per kg even during the rehabilitation phase. Enteral or parenteral nutrition, in case of a ventilated child, enteral nutrition is preferred. It is cheaper, it is physiological. Early enteral nutrition is common practice, initiated within the first 24 hours of admission if there are no absolute contraindications such as malabsorption, multiple inotropes, decompensated shock, severe acidosis, etc. It is always safe to initiate enteral feeds or nasogastric feeds within the first 24 hours of PICU admission. Enteral feeding is started at 25 to 50% of the target volume and increased every 2 to 4 hourly. The protocols might vary among different units. In infants, it is safe to use express breast milk or a hypocaloric formulae as available. Older children, standard formulae can be used. Peptide-based or hydrolyzed formula in special situations can be considered. If there is intolerance, there are multiple practices which do not have any level of evidence at all, but they are still standard practices across ICUs. Prokinetics, use of erythromycin, intermittent or continuous feeds, both have been found to be equally effective. Use of hydrolyzed formula. Measuring gastric residual volume nowadays is not recommended routinely because it acts as a hindrance in progressing enteral feeds. There is no fixed volume beyond which you should label it as feed intolerance, so better not to measure it nowadays. Fluid therapy, these sick children receive a lot of fluids during the initial phase as boluses, as replacement, and then followed by maintenance. Point to remember is Holiday's agar formula for a normal child or in a ward child may not be applicable to a ventilated sick child. We usually start at 70% of that calculated fluid volume, thereby reducing fluid overload. Fluid creep is a new term coined for fluids which are used as dilutions for antibiotics and anti-epileptics. So that also has to be calculated while calculating fluid intake. Prevent fluid overload by maintaining meticulous fluid balances, reducing fluid creep, use enteral route for medications whenever applicable. Early use of diuretics if the child's condition permits when the fluid overload crosses 5%. Lastly, about the infection control practices, with respect to a ventilated child, it is ventilator-associated pneumonia. The original definition was pneumonia in a patient who has been ventilated for more than 48 hours. The traditional definition relied on X-rays, relied on clinical findings and subjective data. The CDC has introduced a newer definition in 2023 which incorporates a lot of objective factors like FiO2 and mean airway pressure or ventilatory parameters which can be used as a surveillance, but you can still treat patients based on the original definition. As per Indian data, this study conducted in AIIMS showed around 25 to 35% incidence of VAP in developing countries. Risk factors being genetic syndromes, use of steroids, multiple intubations, bloodstream infections, PPIs. Common organism, the most common was Acinetobacter. How do we prevent it? That is where bundle therapy comes into play, where these are all, bundle therapy is not a fancy word, it is just individual practices put together and done at the same time, improving outcomes. VAP prevention bundle, this is a standard bundle which is common practice. Some of them have grade 1 evidence, some of them do not have any grade of evidence but still followed. Hand hygiene, head end of bed elevation, daily assessment for extubation, oral hygiene as I mentioned before, care of the endotracheal tube, preventing soiling or preventing the condensates from reaching the patient, suctioning endotracheally first followed by oral, using separate suction catheters for both, stress ulcer prophylaxis and sedation holiday. This bundle has to be part of a daily rounds checklist so that nursing staff are aware at which patient is at risk of developing VAPs. Lastly, about weaning and extubation, there are criteria, but none of the patients need to be necessarily fitting into this exact criteria for you to extubate. Extubation is an art and it has to be performed at the bedside. Though there are rough criteria like mental status, spontaneous efforts, FiO2 less than 50, PEEP less than 7, normal blood gases, nil or low vasoactive support, and the patient has tolerated a CPAP or a PS trial for some time. Adjuncts for extubation like steroids are common protocol. Protocolized sedation weaning, keep in mind sedation withdrawal for a child who has been ventilated for a long time. Decide what support the child needs post extubation prior. Still, there are no specific or sensitive predictors for identifying extubation failure in pediatrics. So, in summary, a mechanically ventilated child needs multifaceted monitoring. General care should not be neglected as nursing care. We have to focus on quality indicators. Nutrition and fluids have to take priority from day one. Bundle approach has been shown to prevent infections and VAP, and teamwork of physician, nurses, and respiratory therapists can provide intact outcome. Thank you.